This is the Whole Care Network. Helping you tell your story one podcast at a time. The following CareLab podcast does not provide health or medical advice. All content is provided for information purposes only. Listeners are encouraged to speak with their healthcare provider for specific healthcare advice and are wholly responsible for the outcome of implementing any tips or information presented.
Welcome to CareLab.
It's CareLab Day, everybody. And this is a really important episode for you to download because you're going to want to come back to it if and when the situation comes around in your life. So make sure you download the episode. Plus, it helps other people find us too. So do us a solid and download the episode. What are we talking about today, Emilia?
We are talking about, this is actually not an if. First of all, this is a Situation Room episode, folks. So buckle up, Buttercup. Here we go. And this is actually not an if situation that you're going to come across. This is a when situation because we are talking about falls, fall risk, and fall prevention. And there is not a single person out there who is not going to encounter a situation in their lives where they or someone that they love or are caring for have an increased risk of falls, and we need to step in and do something about it before a fall and an injury occurs. So this is, as you said, this is going to be a really important episode. Download it. You're going to want to listen to it again, and you're going to want to share this with other folks in your life. So make sure that you do that.
Okay, let's go over the rules of Situation Room.
Okay.
First of all, we came up with a theme, so we did know we were going to talk about falls, but what we don't know was what each other is going to ask us. So I have some questions. She's got some questions for me, and we're going to see how we answer them. And hopefully they'll be useful to you.
There is minimal preparation involved here because that's actually generally how we roll here on CareLab.
That's our normal.
That's our normal level. We just show up and we go over stuff. It helps to be a subject matter expert. We only talk about things that we actually know about, or have guests for those things too. But yeah, so this is going to be fun. We don't know what we're throwing at each other. We're going to do our best job here to take this on. Brandy, you want to go first, or you want me to go first?
I want you to go first.
Okay. Like in terms of,
ask me a question first.
I should have clarified. Okay, are you asking or I'm asking?
You're asking me a question. Ask me a question. My brain is ready to solve it.
Okay. I've got a good one for you here. So what do you do when someone in your life has had a fall? They haven't been injured, but you are worried about them having more falls. You know it's coming, and they don't want to do anything about it.
Ooh, you putting all the situations on me. Okay, so the person did fall. They did fall, but they weren't injured actually, and they're not ready to hear about anything that I gotta say. Basically.
Yeah. Mm-hmm.
Okay. Okay. Here's what I would do.
You said you wanted to go first. I remind you.
I know I did say that, and now I'm regretting it.
It's a really hard one, actually.
This is a challenging issue. They don't want to do anything about it. Okay, this is one way you could deal with it. I'm not saying this is the only way, but this is one way you could deal with it. As a family caregiver, if you're in this situation, what I would suggest is trying to find some reason to get an occupational therapist. And the reason I say that is because your parents don't listen to you, frankly, right? Like you might be 100% right, but you're still their kid at the end of the day.
And can I clarify? This isn't an everyone problem. My parents don't necessarily listen to me. Brandy's parents don't necessarily. Well, I'm speaking.
They listen to this podcast.
They listen.
I don't know that they listen to what I got.
There you go. So it's a family dynamic thing, right? So to your point, getting someone else in. Sorry, continue. Continue.
Totally. So it's not your fault. This is just the dynamics of family life, right? And it's not just parents and kids. It's also like husbands and wives and just like the people you engage with the most, who we should trust the most. We kind of also play off the most. Okay, so this is just like normal. So the reason I say get an OT involved is because now you have a third party, and there, and because OT is so particular about like reaching the goals that the person has, it's unlikely that your person who fell doesn't have some goal, right? And so I think that's a thing that most people can get behind. This is a person, when you're introducing OT to them, this is a person that is just going to come and see what we can do to help make sure that you can stay living in your home, because clearly they want to stay there, right? Because otherwise they'd be open to some action, whether that moving the rugs or moving or whatever. They're not open to no action. They're probably also not open to moving, which means they want to stay home. So that's the thing you can connect on and can say, hey, this is preventative. We just want to see if this person has any good ideas. They're an expert. Then let them come. Let the OT then talk about the questions, ask the question. They're going to say, when's the last time you had a fall? Because that's just what we do. And they're going to talk about it. And then they're going to, in a very non-threatening way, like go through like the root cause of that and come up with some solutions that they're going to be willing to participate in, right? Because it's going to be a back and forth conversation with the OT. If you, this is no hate to PTs, but if you say falls is only about balance, which it could 100% be about balance. But if you assume that it's only about balance and you say, we need to get PT in because you fell, then that feels like an attack to them, because you're saying you're not safe. You can't keep your body up straight. You need to do these exercises. And that might be true. But if you come at it from a more holistic perspective of an OT, just like probing about prevention or about just staying in the home, because that is true, then in the back end, you end up with the answer that you need.
Let me add on to that just a little bit, in that as you said, sometimes falls are about balance, but usually falls are multifactorial. Yeah. And when you have an OT come into the situation, they're going to look at all of those factors and see how they work together. So, and as you said, the goal is going to be about it's going to be about a function. What do you want to be able to stand up and cook? You want to be able to walk to the bathroom without having fear. Like, what is it that you want to do? So we can frame that discussion around something that's not just about falls. It can be about whatever that person values. And then because we can address lots of different factors that involve, we can also meet that person where they're at in terms of what they are willing to address. Because again, to your point, usually we think about falls, we think, oh, this person is having trouble walking, they need a PT. But what if this actually has to do with their vision? What if this actually has to do with some arrangement of the furniture? What if this has to do with a habit or some other thing that we can take an intervention on? Where can we meet that person where they might be willing to make some change in order to make something that's of value to them doable again? And so there's just a whole lot more tools in the toolkit to start addressing that problem. And to your point, it takes you out of that situation and says, okay, we're going to have this expert lead it and just give you some options here. It's all about options. It's all about choice.
Exactly. And then when you make it about choice and options, then they're part of that and they get to choose. And then when you don't choose things that you don't buy into and that you're not going to do. So then we get the outcome that we want, which is some level of change probably.
Okay. So second part to the situation room question though, is there anything that people should absolutely not do in this situation if they can avoid it?
Yeah. The thing I would not do is make a bunch of proclamations and do a bunch of changing without their consent. So if we're dealing with a person who doesn't want to change anything, you see that there's problems, maybe you even correctly identify that there's some problem. You just go in there and start taking up some rugs, moving some stuff around, proclaiming that they need to go to rehab or whatever. That's just going to strain your relationship and they're going to rebound really hard on that and do exactly the opposite of whatever it is. I mean, because that's just human nature. And so if the goal at the end of the day is to help this person be safer, stay living in their home, have fewer falls in the future or no falls in the future, then we need buy-in. And you can't get buy-in if you just like command over the whole.
Totally. Absolutely. Yeah. Nailed it.
Thank you. I'm here all day, guys. Here all day. Okay. So you just made me have to go for a home run. I was going to ask a simpler question, actually, as my first question. So since I already gave this answer, this answer, give us a little bit different option. What do you do if your person fell, their hip hurts, and it's not fractured? So let's say this is in the acute moment, okay? They called you, they said they fell, you helped them get up. Maybe it went to the ER and you saw that it's not fractured, but now you're not a part of the healthcare system. It's not fractured, they send you home, you're still worried. What do you do?
you're still worried about them falling. Yeah, that's one thing. And they're having pain. That's the other thing. Yeah.
That's the other thing. And they're having pain.
So, I mean, partly I have to revert back to your original answer. So we had a fall. We should call in an occupational therapist. And that might mean that going to the primary care doctor and saying, hey, can we get an occupational therapist out here for home health or whatever it is, or in the outpatient clinic, could mean while you are in the hospital at that point of service, asking some hospitals will actually like have an occupational therapist come see you in the ER, although that's probably not the best scenario for you here. You really want to have an OT in your home
to the house,
so that they can look at the whole big picture. That's ideal. But if you're sitting there in the ER, and they're about to send you home, say, hey, we don't want this to happen again. Can you put in an order for home health to get an occupational therapist out to the house? So like, that's your opportunity to get those services initiated right there. And then kind of take it that whole area, that all those things that we already talked about before. Hey there, it's Emilia. Listen, I am so thrilled to have a great resource like Ask SAMIE as part of the CareLab team. And here's why. It's a game changer for aging in place because it makes it so simple. All you do is ask. Just type in your question or even tell SAMIE what the problem is and get tailored solutions. Everything from innovative adaptive equipment to comprehensive resources. It's a great way to become more empowered, to live more independently, and to live with greater confidence. And my favorite thing about how Ask SAMIE works is it's deeply rooted in dignity and practicality. So whether you're a fellow therapist, a care partner, or someone who's seeking solutions for themselves, visit www.asksamie.com. We're going to link it in the show notes so you can find it there. Start making home more accessible today. Now, back to the show. Now, the problem is if someone's going home and they don't necessarily have like an acute severe injury, like a hip fracture, a broken bone, but they do have pain. A lot of what then you might be in a situation where that person does not want to get up. So they don't want to get up. Maybe they are now having some fear about falling. And that fear in and of itself is, of course, a big predictor of future falls, but then also that lack of additional mobility. So just sitting around and not wanting to get up, that can be another cause of additional future falls. So what do you do there? Again, I think it's very important to have professionals in this situation who are coming in and being those primary folks who are providing the recommendation and who are setting you and your loved one up for success. Because to your earlier point, not only maybe you do identify the right things, maybe you don't identify the right things, the family dynamics that are involved in this situation are unlikely to
bode well for your favor.
Bode well, yeah. But what we do want to do is provide enough supervision and safety and support to give that person the confidence that they can get up and move around as much as is safe for them. We actually have at Higher Standards Caregiver Training, there's a lot of educational content on there for family caregivers, specifically about like safe mobilization, safe equipment usage, things like that you can use to kind of help increase your understanding of how to do those things safely. So I would recommend checking those out, especially while you're waiting for maybe that individualized like plan of care from occupational therapy come out and get started. But just trying to make that person as comfortable as possible, provide the right supervision and level of assistance so that they can be confident enough to start mobilizing on their own, and really getting that OT in there as quickly as possible to make sure that any equipment that they needed is appropriately recommended, that there is a plan to address this overall holistic reason that this fall occurred, and get people started as soon as possible down that path. Because what we don't want to do is
there's a thing not to do.
There's a thing not to do, and that is to say, whew, well, thank goodness they didn't get hurt. I hope that doesn't happen again. And
which is the thing most people do.
Which is what most people do. And do nothing. Because I guarantee you, if there has been a fall, there is going to be another fall. And it is only a matter of time until one of these falls does result in an injury that can be absolutely life changing. So we don't want to sit and like go, whew, thank goodness that didn't go that badly, and then cross our fingers and hope for the best.
So what I hear in recap is that try to get an OT out, even though there's no actual fracture and they might not initiate sending one, but ask for one either from the ER doctor or from the primary care doctor, and feel confident because it's not fractured that you help them move, that you encourage them to move even though they have pain, and then lastly to not ignore it and act like, whew, that's over, and keep going.
Yep, absolutely. That summed it up quite nicely. Okay,
sweet.
Are you ready for another question?
Yes.
Okay,
yes.
Hold on, I gotta look at my list. Just in case if you're wondering, dear CareLab listener, I have a list for everything. I have so many keep notes on my phone, it's crazy. Because I just think like I'll just jot down notes all the time, all day long, because otherwise I won't remember it. Okay, what do you do if the person that you love or that you're caring for, you feel like they're not walking super well, but they haven't had a fall yet, and you think that they might need some sort of supportive walking device, an assistive device like a walker or a cane or something like that? You think that they might need that. What should you do? Who should you call? What should you not?
Okay. I think they need a walking device because their balance is not looking good. Their walking is not looking good. The very first thing I'm going to do is try to get an evaluation with a physical therapist. That's what I'm going to do, because this is what they're expert at, right? Is analyze their gait pattern, determine if this can be rehabilitated, and if not, or if so, and also needing a device. And then in what situations we're going to use that device. And while walkers are very ubiquitous, you see them everywhere all the time, they're easy to access, that doesn't mean that that's the right scenario, the right thing that you need, even though you could get it. So let an expert help you decide. It's covered by your insurance to see a physical therapist, so have them help you figure that out. The other thing is like using an adaptive device is good. Clearly, I sell adaptive devices, right? I'm for them, but that's not the only way to solve a problem. And sometimes it has bad effects. So like let's say we prescribe somebody, you say, let me get my mom a walker and she'll use it. Let's say she gets a walker, she relies on it more, she gets weaker, and we're getting worse without like adding other inputs like additional exercise or walking, or figuring out why she's walking more fearfully. So it's a complex situation, and you should get to help you figure what that next step should be, and hopefully to make the body strong. The other thing I would also do is try to encourage more movement, and whatever format that can take in a fun way, because nobody likes to do exercise, but there's lots of ways to get exercise. And so I'll try to find ways to do that, whether that's like, hey, do you want to go with me to the store and walk a little bit more, or you take a walk around the block, or I don't know, whatever is interesting that requires movement, try to do more of it. The thing I would not do is simply go pick up a device that I think they need and give it to them. Because if you don't set it at the right height, or it's not the right thing, we don't clear enough space in the home, it can be more of a hazard than a help. I mean, like a good example is when somebody has dementia or Alzheimer's, sometimes adding a device is actually a big fall risk, even though in other situations they would be the perfect candidate for a walker. But for somebody who's not going to remember that or know how to use it well, it might be a detriment. So don't just go pick up something without getting like some clear advice from somebody who's expert at it.
Yeah, I'm so glad that you mentioned that last part, that like these are not like one size fits all recommendations or situations. Basically, it's always an individualized recommendation. And again, if you have someone who has a cognitive impairment, you have someone who has dementia, at a certain point, these folks are not necessarily capable of new learning anymore. So if you introduce an assistive device that someone has never used before, they're not going to be able to learn how to use it. It can increase their fall risk, and it's going to give you nothing but a headache, because you're going to be sitting there 12,000 times a day. Use your walker. Get your walker.
Get your walker.
Get your walker. And it's not going to sink in. So yeah, great point. Amazing. All right, do you have another one for me?
I do. Okay, so when I think about falls, I'm always thinking about when somebody's spending some time in the hospital, and you got to wear those yellow socks. You got the thing on the door that says fall alert risk, yellow band on, and they want to get up and use the bathroom because there's not enough people there to come help them use the bathroom when they need to. Yeah. And so what should you do if your person is in some kind of facility and they won't stay in bed at the hospital, and you know that they're fall risk? How do you handle that?
Oof, that is a really, really tough scenario. Partly that depends on their level of cognition, right? In terms of, is this person who has no cognitive problems, they're at full mental capacity, they can make decisions on their own, and they are capable of problem solving, new learning, all this stuff? Or is this someone who has a cognitive impairment, or they have dementia, or some other reason why they're not currently able to make good decisions? Maybe they're more disorientation, because these do have different solutions. I will say that neither one of them are necessarily easy. And partly that is because of the fact that we simply don't have enough bodies a lot of the time to provide the level of care and supervision that we care. However, let me start with, let's say you have someone who they need to get up and go to the bathroom. They don't want to wait, or maybe, so this is a cognitively impaired person. Maybe they can't even remember they're supposed to push that silly little call light, right? Like, what is this thing? I don't know. I'm getting out of bed and I got to go to the bathroom. And they're not going to follow the instruction. We want to really be strong advocates in that situation for having a one-to-one sitter in that room.
CareLab listeners, it's Brandy, and as the founder of a platform made to make aging in place easier for everyone, I knew it would be incomplete if we did not have education, especially for caregivers. So whether you're a family caregiver or somebody who trains a whole organization, Higher Standards caregiver training videos are for you. I'm so proud that we were able to partner together with Emilia in order to provide these to you, because they're easy for everybody. You get great occupational therapist-led training on topics like transfers and how to care for someone as they age, or maybe as things change when you have Parkinson's. So no matter if you're the loved one who doesn't know exactly what to do next because things are getting different, or if you're a professional who trains caregivers that go into the community and you need some quality education, you get both from Higher Standards Caregiver Training. And you need to check them out at higherstandardscaregivertraining.com.
For providing higher levels of supervision, certainly things like bed alarms, chair alarms, these are good tools that we can use, but they also only work well if we can respond to them in an appropriate amount of time to get there before something happens. So this is probably like a wildly not popular answer, but the fact is sometimes people just need one-to-one supervision. They're going to be able to prevent falls. Now, one of the things that we see more with the use of technology in hospitals and facilities is like camera monitoring in rooms. So a single nurse from their nurse's station can watch everyone, and if someone is getting up out of bed, they can send someone directly there. And so there are ways that we can help solve this problem with the current staffing issues that we have. But sometimes it's really up to you as a caregiver to make sure that you are advocating for those solutions to be put in place, or for that level of supervision to be provided, because sometimes we can't just tell people what to do and expect that they're going to remember and follow it. In general, actually, cognitive impairment or no cognitive impairment, we can't just tell people what to do,
right,
and expect them to always do those things, right? People have their own free will. They have their own opinions. They are going to take things into their own hands. And to a certain extent, we actually have to respect that.
right.
So let's go to this other scenario where we have someone who is in the hospital. They can't get up safely to use the restroom by themselves, but they need to get up and use the restroom, and they don't want to wet themselves in bed. They don't want to use they don't want to have a bowel movement in the bed, which is totally understandable. And guess what? We don't want that to happen to them either. It is really important in this situation for that person to be a good advocate for themselves. And part of that is being proactive in when you are pushing that call, but for when you push that call light. So do not wait until there is an urgency or a sense to go. I really recommend to folks that they push that button on a schedule. If you know that you usually have to go every couple of hours, hit that call light every hour and a half. Do not wait for you to have that sense of urgency before you hit it, because you don't know the care attendant, the nurse, the CNA, they have several people on that hall that they are having to take care of right then. And they might be in a situation where they just cannot immediately step away. The same as you wouldn't want them to immediately step away from you in certain situations. They just can't go. They cannot leave the person that they're with in order to come meet your need immediately at the time. And that is just the reality of the situation. So plan ahead, set a timer on your phone or wherever, and set it to push that call light at a regular interval where you're not going to have urgency. It's going to give them enough time to get there. And then whether or not you got to go when they get there, get up and go. Empty that bladder. Just take care of it. This is also a really important thing to do to prevent learned incontinence, which can often happen when folks are not able to get up and use the restroom safely, and they're not able to get assistance quickly enough to get up and out of bed. They just end up kind of like going in the bed because they don't have another choice. And that can lead to learned incontinence in the bladder and in the bowel. And we want to prevent that as much as possible. So setting your own timing and being a good ad for yourself is really, really important in areas.
I think those are such strong answers. And it really boils down to advocacy about whatever the person needs. The other thing I would add is that sometimes the facility environment creates the fall. And so if you know the person is, let's say they're cognitively with it, and they're like, it doesn't matter when I push the call button and nobody comes, or I don't know in enough time. What can we do in the environment to make it easier and safer to go to the bathroom? Can I ask for a bedside commode so it's right there? Maybe they could be safe with standing and pivoting and going to the commode. Maybe it's clearing the pathways and putting the other things that the person needs on the other side of the bed, so that there's not so much stuff on the way to the bathroom, and we can create a situation in which it could be safe to walk to the bathroom. And also, you can also ask, like, hey, they seem decently okay to get up. Can we have somebody evaluate whether they can be independent in the room? That is an actual designation inside of facilities, and a PT or OT would come and make sure that they've got the setup that they need in order to be independent, and kind of give their stamp of approval to say this person actually could get up and use the bathroom on their own. And so you can advocate for somebody to decide if whether that should be true or not. Because the default is everybody's a fall risk, everybody's staying in the bed, so somebody comes and helps. And at some point, the goal is you get better. And so at some point during the hospital stay, they might be able to be independent in the room, and you just need to get somebody to clear them for that.
Yeah.
I would just add that in there. What is something that they should not do?
So for someone who is completely cognitively intact, they should not climb over that bed rail. They should not climb over that bed rail with the pants hanging half off and one sock off and one sock on, and do whatever it takes to get to the bathroom, right? To your point, I'm really glad that you added those comments in there, because we can take steps. Sometimes people are going to do what they want to do regardless, and we have to actually be respectful of that. People have the right to make their own decisions. How can we set up the environment to increase their chances of success, and really think about that individual person and their needs, as opposed to what the setup usually is or what we think it should be, right? So that's a really strong point. I'm so glad that you brought that up. But yeah, we don't want to kind of sound like a broken record here, but we don't want to do nothing. We really don't want to tell people just go in the bed, unless there is really 100% truly no other option. We really don't want to tell people to just go in the bed. I feel very, very strongly about this, because the problems that it causes, again, in terms of learned incontinence, which can cause all kinds of ongoing issues for folks. It actually can increase people's fall risk because of those incontinence issues carrying forward for a very long period of time. It increases your chance of wounds, infections, all kinds of things. So I guess those would be my big do not do this. You probably, I'm gonna guess you have something helpful to add to that, though.
No, I was gonna say, no, I think that's key.
Okay.
We shouldn't just be okay with people just going on themselves, unless there's literally no option for dealing with that. They are bedbound and they cannot get out of the beds, without a Hoyer lifter and a bunch of other stuff going on. We should be initiating getting up and going to the bath. That's it.
Yeah. All right. I think that was an excellent situation room.
Yeah, we hit the falls.
We sure did. If you enjoyed that, as we said at the beginning, I am sure that there are folks in your life, if not you right now, who would benefit from having that information. Please make sure that you're sharing this episode with them right after you download it. Make sure you're checking out some of our other wonderful episodes. I'm going to brag about our podcast a little bit here. So bear with me. Y'all, we have a resident pharmacist. We have a resident hospice nurse. And when I say that, I mean, we have these recurring guests that keep coming on. We have physician who's a recurring guest. We have a hospice nurse. We have a pharmacist. We have had multiple death doulas on, There is such a richness of content and expertise. Take some time, find the episodes that meet your needs. I guarantee there are episodes here that resonate with the things that other people in your life are going through too. And our goal is to deliver to you really, truly valuable information, whether it's from us or from the guests that are on the show. So take some time, check out our episodes. Please download them. Why? Because when you download them, it helps to make sure that other people are finding the podcast here. So we really appreciate that. Make sure to like, subscribe.
And come back and hear us next week.
All right, we'll see you next time right here on CareLab.
Bye, everybody.
Bye.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.